Welcome to Mercy Medical Center's live webinar. Today we'll be discussing the concept of the medical home, a new and innovative approach to health care that starts with your family doctor. Joining us today is Dr. Timothy Quinn, President of the MercyCare Community Physicians. After his discussion, he'll take questions from our audience. To submit your questions anytime during the discussion, go to the window in the upper right-hand corner of your screen and type in your question. If you don't see the screen, click on the orange box with a white arrow. Your questions will be anonymous, completely confidential. Let's get started. Dr. Quinn?
Well, thanks for the invitation. Your questions are anonymous and confidential, but I might poke fun at you a little bit anyway. No, we have any questions are welcome. This is the medical home is a concept that's been around for a long time that is finally getting some legs. And when I'm in my elevator speech for this, is if I have only a few seconds to describe it, people ask me what is a medical home, and the most simplest answer is it's all the things you think your doctor is doing or should be doing, but we're probably not. And it is an approach to comprehensive, coordinated care across the spectrum of life. So it might deal with newborns, it might deal with end-of-life care, it might deal with just wellness. You know, we have a great deal of focus on maintaining health, promoting wellness, preventing things like obesity and diabetes have obviously become huge issues. You know, just in general terms, when we talk about how do you approach your care with a physician, because part of what the medical home is developing a relationship that depends upon a partnership. It's a mutual level of accountability and responsibility between you and your provider. And just some tips to kind of walk in the door with, knowing what your insurance will pay for. You know, these are just some general 5 tips. Preparing for your visits. You know, doctors we love to problem solve, but we're also simple-minded at the same time. So you get to about 2 to 3 problems, really focusing on the things that are important questions for you, so we can thoroughly attack each of those things and develop a good treatment plan for you. And then finally, you know, what are the questions that you have about medications? What are potential interactions? One of the big things we see, even with the professional population, is completion of antibiotics. So if they tell you 7 days or 10 days, finish the course. Some of the worst people at finishing medications as they're directed are physicians. So that's something we've learned from ourselves. Finally, you know, when you look at how do we get engaged as a community and as a culture into where our healthcare is going, a lot of it has to do with the general population, the well population. How do we think about where we are in our health status, taking into consideration maybe your genetics, maybe whether you're an alcohol or tobacco user, our tendency towards obesity, cholesterol, those kinds of things. So we've become much more thorough at making sure we have measures of weight, obesity on an annual basis, taking the general well population and doing things like glucose screening to look for early signs of diabetes, and blood pressure monitoring, lots of measures out there. And finally, when you look at how the care is going to be coordinated for you in the best way possible, we look at what's the best match. You know, who's your provider? Are we accessing all the resources that are possible? Because sometimes it just takes simple education. I have in my exam rooms at my office, I have signs up that still are, or we're still developing the communication tools of how we let patients know what we have available. But at the end of the day, these, you know, when you look at the comprehensive relationship, the partnership that goes on between you and your provider, it comes down to the patient-centered medical home, and it's kind of the catch-all that describes this model. So the general question of what is a medical home, because you're going to be hearing more about this. The history of it is that it goes back to the late 60s. It was developed by high-needs groups in the pediatric community. Pediatricians developed it. You know, our medical system in this country is based on getting paid to see more visits. So as you can imagine, you know, through the last several decades, there hasn't been a large segment of the medical community that says, yeah, let's take this on so we can see fewer patients and spend more time on each patient. Well, eventually there's been enough momentum in what is the right direction, which is taking good care of large groups of people with individualized comprehensive care. And in our culture in medicine over the past 20 years has been evolving more towards monitoring of how we do our job, not just how many people we see. And Mercy in particular, we have our internal quality initiatives, which gear us all in the direction of access for patients when they need it, and measurement of how we do it, things like cancer screening, diabetes screening, and monitoring of chronic diseases. So our entire physician network is geared towards providing not just quantity and access, but quality of care. And we're all graded on that, and we all have visibility to that. So it's developed a whole new accountability for what our expectations are in this medical community. At the end of the day, what the medical home has become on a national level is integrated into what healthcare reform is. And even if healthcare reform doesn't take the path that it is currently on or has been directed on by the legislators, Medicare is still going to continue to push for models that address holistic care for patients. And the result of that is that we have a coordinated approach within a practice that's personalized and addressed at the individual patient level. Even if you don't have any medical issues, even if you aren't on any medicines, we should still be looking at, okay, if this is a 20-year-old or 30-year-old, for example, male or female, are there cancer screening things that we need to be thinking about? Are we looking at screening for diabetes? Are we counseling on their weight and on their diet? A good example is, when I talk to patients about colon cancer screening. Now, the recommended age for colon cancer screening without any family history is 50. Well, what I found over time, I'm a little bit slow, so it took me a while to figure this out, but if I started talking to people about colon cancer when they were 50, it took me to about they were 52 or 53 to get the colonoscopy done, because as you can imagine, not too many people are excited about that procedure. So what I do is I start thinking about it, and my nurses and my team members are all reminding me, hey, this person's, I realize it's simple math, but if they're 48, they're going to be turning 50 in a couple of years. So how do we think about that? So we actually start talking about a 50-year-old's colonoscopy before they're 50. And so you just have to be thinking about the well population, not just the disease, people with chronic disease and other things. What coordinated care becomes especially important when you look at people that has more severity of illness. They end up in the emergency room. They end up in the hospital. They might be undergoing chemotherapy or some sort of cancer treatment. All of this becomes critical in terms of how the information and the treatment plan is handed off from doctor to doctor. I can tell you the traditional model of medicine is if I send someone to an oncologist for example, I might get a report back from them. Well, what happens if my fax machine doesn't work, or the mail gets misdelivered, or I just miss seeing the report? 2 pieces of paper are stuck together and I don't see the plan. Well, this takes it a whole next step. So when I send someone there, I have someone on my team who's looking for the feedback from that physician, from their office, and specifically what is the plan and when's the next set of tests and when are they going to see that doctor back, and we incorporate that into their personalized health plan. So their personalized health plan might be things like, well, your tetanus shot is due in 2015, your colonoscopy is due next year, and your chemotherapy, according to Dr. So-and-so, is going to continue for another 6 weeks, and then your follow-up mammogram or whatever it is in 6 months. And that is all in one piece of information. So because of the way that things work now in medicine in this country is that you get fragmented messages from 10 different doctors. If you've been in the hospital or talked to people in the hospital, they don't know who half the doctors are that walk in the door, and we need one central repository for consistency and clarity of that message. So at its heart, that's what the medical home is all about. It's centered on the patient's experience. How do we provide good access to care, good follow-up on testing, and make sure we don't let anything fall through the cracks? Excuse me. I talked about healthcare prevention a little bit. Again, we are looking for opportunities to review the literature. We're always updating what our protocols are for cancer screening, for example. When you look at the national rates, just to give you a sense of where the quality of healthcare is in this nation, when you hear the United States bash for healthcare compared to other countries, this is the kind of thing they're talking about. Medicare colon cancer screening rates, if we're lucky, are 50% of the time. In MercyCare throughout our system, since we started monitoring for colon cancer screening, we're at almost 90%, so almost double the national rate in that population. So we're really seeing some great results from that. And a lot of it is just having a group of physicians that are really focused in on what's important and willing to commit the resources to make it happen. And then holding ourselves accountable, and also understanding that if we don't explain it well, if we don't make it compelling to the patient, no one's going to get it done. Because let me tell you, drinking a gallon of Go Lightly is not a fun thing. So we just based on national statistics, we know, at the bottom of that slide there, you can see the statistic. If everyone over the age of 50 had colon cancer screenings, most of these colon cancers could be avoided. And basically, for every 200 or 250 colonoscopies we perform, you're saving someone's life, because you're actually getting a polyp, and they're getting rid of a polyp that would likely turn into a cancer at a later date. So some neat opportunities. So we're pretty excited about where this is going as a community. I'm just going to show you a quick example here of a patient that was caught through our quality program of screening for colon cancer. Not sure. There we go. Here it comes. Hang in there.
This story ends on a happy note. When 68-year-old Michael Phelan went in for a routine exam, his physician, Dr. Tony Myers at MercyCare Marion, recommended Michael have a colonoscopy.
He asked me if I'd ever had a colonoscopy, and I said, no, I really haven't.
It wasn't just by chance that Dr. Myers ordered the screening. It's part of a new evidence-based preventative healthcare program at all MercyCare clinics. Doctors are committed to spending more time up front with patients to prevent health emergencies later on.
We know that he was overdue for a colonoscopy, even though we weren't really focused on that at that visit. And so that allowed us to react to it. And that has really had an impressive effect on how many of those things are actually getting done.
It's a good thing for Michael. His colonoscopy caught early-stage colon cancer. He had surgery the next day to remove it.
It hadn't gone into my lymph nodes or any other organs in my body, so I was really thankful.
For more information, visit MercyCare.org.
So really a neat story, and I, as president of the organization, I get stories like that. He's one of about six people that have colon cancers we've detected as a system since starting this program within Mercy a little over a year ago. So it's a really a neat thing to be part of a healthcare network that's committed to an objective like that. Just in case you're curious, Michael, he played the piano that well before the colonoscopy, so there's no guarantee about that. But the benefits of this. Now, if you look at what our expectations are when we go to the doctor, everyone assumes that you're getting 100% of quality care at every visit. We have a great, even if you have a great relationship with your provider. Just for fun, sometimes I put up a slide in discussions to show what's all the recommended care at every visit. Even if you go in for a cold, there's a list of about 25 things as a family practice doctor I'm supposed to be screening you for once a year. That includes things like smoking, alcohol use, depression, gun safety in the home, the recommended screening cancers. I mean, there's just a huge list. Immunizations. So, you get the point. I don't have to go through the whole thing. But the bottom line is, without some sort of plan for that, those things just never happen. And so a lot of the recommended care that we should be doing isn't there. Well, how do we fix that is developing a different kind of relationship with patients, because the onus is on both parties. I mean, both the clinician and the patient have to have some sort of ownership and responsibility. And, okay, I'm going to give you this. And I tell patients when I give them a treatment plan, part of this is to remind you what is going on. Part of this is also for you to hold me accountable. This is what I said our plan is, and we agree on that plan, and then we hold each other accountable for how we follow up on that. The other piece that comes into play is communicating with other providers in the community in a little more face-to-face sort of way, and also having resources at my disposal within my nursing staff that they develop relationships with other nurses within the Mercy network, within the referral network, within things like physical therapy, and like for our diabetic center at Joslin, for example, our nurses, we've developed a line of communication so they can just pick up the phone and call each other. They have their own relationship. So it's tightening up all of the network of people that are responsible for your care. How do we do at screening for all these things? You know, some other measures we've taken on this year as part of the Medical Home Initiative are making sure that we have blood pressure screenings long before people develop that. As I said, colon cancer and breast cancer screening. The same or similar statistic that I mentioned for colon cancer is also true for breast cancer. We know that for every 200 or 300 mammograms we order, we're going to pick up some cancers there that would have otherwise been missed, unfortunately. So we've been successful at finding some things, and that we're going to lead to some improved outcomes for patients. The other benefit of medical home and enhanced access, when you look at today in terms of our own expectations of our healthcare environment and just services that we get in general, it's about when can I get in that's convenient for me. And so we've responded to that by doing more extended hours, more same-day appointments. Our clinics are looking at having extended hours, even weekend hours, as a way to have accessibility for patients. And that also includes electronic format. So we're on the cusp of having an opportunity for electronic visits and even live chat or video feeds with certain members of our physician group. So that's still in a trial phase, and we appreciate Geometric's work on that. The patient portal, you'll hear more about that in the mainstream media. And Lynn, what's the magazine out right now that was talking about medical home?
Consumer Reports.
Also, so Consumer Reports is talking about medical home right now. So it's really starting to get into some of the mainstream media. You're going to hear more about it. We've been working on this initiative for about 2 years now. But things like patient portal are going to become more commonplace in the lexicon. And the portal just refers to a way for patients to log into a secure website. They can get lab results, ask questions, request appointments, get refills, and we're again, that's going to be the source for our electronic visits as well. So that last piece is in development. But I have patients right now who, I saw someone this morning, for example, that we did a cholesterol screen. They'll log on there tomorrow, be able to see the results and my recommendations based on those test results. So it's really a neat thing for people that want to use that route of communication with their doctor. And finally, the electronic health record. So this is when you talk about a nationalized health record, which is the big push right now, trying to get access from any point. We want patients to have access. We also want to have emergency access. If you end up in an emergency room in Atlanta, we need to have a way for someone to get to your medical history and your medications and allergies, while at the same time having it be secure data so no one else can get there that you don't want to see it. And so we're, as a system, we have an electronic medical record. And it's really a neat thing because you might be seen in my office one day. Well, if you go to urgent care over the weekend, they can access your records if they're to see what medications or allergies you have. And we're also working in conjunction with specialists in the community so that we can communicate those records back and forth. And most importantly, we have a project in place where we're going to make it so the emergency room doctors in town can access your electronic record. And again, that's all subject to patient approval. So we're intensely careful about secrecy and the privacy of records until the patient approves of it going anywhere other than what I can see. And we'll just open up for some questions here too. And this is a favorite topic of mine, so I will bore you to death with hours of talk on this. So we'll just open it up.
And to remind you, your questions can be submitted from the box in the upper right-hand corner of the screen. We'll have a first question here. Can you tell me, will all MercyCare clinics become medical homes?
Yeah, that's the goal. We have, right now, we have one clinic that is applied for medical home. There's actually a certification on a national level that you go through. So even if you're functioning, have all the pieces of the medical home that you're offering, to actually say that you have to go through the certification process. So that's what we're in right now. My hope is to have about 70% of our clinics as medical homes by the end of this year, and the remaining ones over the next year after that. But the services available are largely in place now, with a few exceptions.
Okay, is the new, next question here, is the new Mercy Cancer Center planning to use this PCMH model?
That's a great question. I think we are coordinating with the Cancer Center to do exactly that. And the medical home is with the patient at the center, the patient with an attachment to where their primary care doctor is. So you might go, if you or a family member has a cancer that's treated at the Cancer Center, they might have a navigator or a specialist coordinator who's at the Cancer Center, walks you through that process, and then when that handoff happens to go back to your primary doctor, we've set it up so that cancer navigator will actually contact the physician or the health coach, who's the healthcare coordinator within my clinic, to say, okay, here's the plan for this. Here's what's going on with this patient. They're having nausea. You might want to follow up on that. And then the health coach or the physician might call the patient a day or two later and say, okay, how's this going? How's that going? And what you don't want to have happen is have the patient end up in the emergency room, or one doctor knowing what's going on and the other not. So that is all these people within the support group are to close the gap on that communication.
Sounds great. We have another question. Will this model of care increase the number of times I need to physically go to the doctor, or will there be more access to my doctor online?
The answer is yes and no. Does it require you to go to the doctor more? Actually, the way the medical home is set up, if we're thinking ahead and we have a comprehensive health care plan for people, the need to go to the doctor is actually less. And it also has access, so if you're sick and you need to go today, we have that availability there. We actually, some of these things with our online access, I have diabetics, for example, who send me their blood sugars through a secure website, and we do some of those things and now I only see those patients twice a year. I used to maybe see them 4 times a year. So it really depends on the situation, but the opportunity is there, and the purpose is to actually decrease how often you have to go to the doctor for those things.
We have a question about screenings. Do I need to call Mercy to sign up, or can I sign up online?
It depends which kind of screening you're thinking of, but usually your best bet is going through one of our, if you don't already have a primary care provider, going through one of the MercyCare clinics, establishing, a relationship with one of our providers there, and just talking about whatever it is you want to do, and then they can also give you the rundown on what's recommended for your age range.
Question, is this concept, the medical home concept, new to the Midwest? What other communities are doing this and doing it well?
Yeah, there are not very many. It's nationwide. Again, the history of it, it's been around for the concept has been around for about 4 decades. No one started doing it and making a serious commitment to it till the last decade. There's actually only one clinic in Iowa that is certified as a medical home. So we're blazing a trail in terms of what kind of care we provide and what we're paying attention to within MercyCare. If we're able to successfully get all of our clinics up, it's a very unique environment in the Midwest or even nationwide to have that level of commitment to this kind of care.
Another question about the MercyCare docs. What is the best way to locate and identify a MercyCare doctor?
It depends if you have web access or not. MercyCare.org is a website you can reach. It has a listing of all of our physicians by location. That has bios for all of our doctors and shows their particular areas of interest, if they're interested in wellness or women's care or diabetes or whatever their particular area of interest might be. I find that to be the easiest. But if you're just simply looking for who's taking new patients and what's the nearest to your site, you can also call the main number at MercyCare, and that's 369-4500. I think so. I think that might be Z102.9 too. I'm not sure.
No, we got the thumbs up.
Okay.
That's correct. Another question about medical records. Do the medical records from the different offices in urgent care talk?
The office, within our offices, MercyCare shares the same medical record with our urgent cares, which is amazingly important to me. You know, as a provider, someone might go into urgent care on a weekend, and then they might call the next day, and I'm on call, and they're worried about a particular symptom or if things are worse, and I can log on a secure website from home and see the urgent care record. Or if they show up in my office on Monday, I immediately have access. Now that, you know, the paper format, I would get a fax from them maybe a week later or something. So I was relying on piecing together the sketchy details from the patient's view. Now the emergency room, that's the other question is, that's the piece we're working on right now. And within the next few months here, we're going to have that availability where the emergency room doctors will be able to see that as well.
Now we have a question about insurance companies. Will insurance companies pay for screenings such as DEXA scans, lipid metabolic panels, if the patient is not having symptoms but is wanting to know that everything is working the way it should?
Great question. If I had my way, all companies and insurance plans would pay for this. Some do, some don't. It's largely a reflection of your insurance plan. We have a great commitment. We have great employers in this community, and who've made big investments in wellness plans, and so they're very effective at covering that. In fact, a lot of them just do it on site, and we're working with them to make that a smooth coordination. So when you do a screening for diabetes or for cholesterol, for example, that your primary doctor gets those results, is able to review those with you if they're abnormal. And it's important to me because as a consumer of healthcare, I don't want to do the same test twice. So if someone comes to my office once a year and they have a wellness plan, I say, well, just send me those results, make sure I get them, because I don't want to retest you. That's just more dollars in the healthcare system we're spending. So the more we can streamline that, the better. But no, I've been very impressed with the commitment in the employer groups in the community to pay for these things.
What happens if I get a majority of my care at the University of Iowa, but also see MercyCare physicians?
Yeah, I have several patients like that. I mean, we have a great community. We have great surgeons in the community, but the fact of the matter is there are some cases, some rare congenital disorders in children or rare types of cancers where people will end up going to the university for a lot of their care. And it's great. We have good communication with them. The physicians there that I talk to will either send me a secure email with follow-up tests or a plan. But again, all the medical home about that is all about that. So even if someone goes for the majority of their care somewhere else and they only see me for an annual physical, I view it as part of my responsibility is the data keeper and the person that assimilates that whole plan into a piece of paper, a document that is understandable to the patient. So we might have, part of their care summarized from the university. The other part of their care plan is summarized from their local provider. But yeah, we incorporate that into what we do.
What a great plan. Sounds excellent. Will the electronic medical records patient portal fulfill the meaningful use requirements set by CMS?
Okay, now that sounds like a loaded question from somebody from IT.
And you might want to explain what CMS means first.
The answer to that is yes. I think the good medical records that are coming out on a national level, their hurdle for being able to successfully market on their end is being able to meet the requirements set forth by the government. So CMS is Medicare. It's the administrative body of how our healthcare dollars are spent in this nation. So the government dollars go to Medicare. Medicare sets the rules for how they're going to pay doctors and hospitals if we meet a certain set of rules. And the rules that have been set forth in terms of what are the capabilities of the electronic medical record are called meaningful use. So meaningful use are the set of rules for things like, well, you have to be able to send prescriptions electronically. You have to be able to communicate to your patients electronically if they want that. You have to be able to make sure that tests that you ordered were actually done. And again, these are all really common sense things from a care perspective. Like I want to make sure that I can, do tests and that the tests are done that I ordered. But you have to have a way to track that. So meaningful use is just a set of criteria set up by the government that says, look, if you're going to use an electronic record, make sure it does these fundamental things. Otherwise, you might as well be keeping track of patients in, Microsoft Word or something.
What are some of the requirements for medical home certification?
Those are a lot of things. Again, it's kind of the common sense things you assume your doctor already does. It's things like following up on tests. If I order, say, cholesterol tests on 100 patients in the past month, I have a nurse that's dedicated to making sure all those tests were done, number one, and number two, that the results were communicated back to the patient with the plan. The traditional model of medicine, if you look back and, when we were all kids or even when our moms, dads, and grandparents went to the doctor, it was you go to the doctor when you're sick. The doctor says, come back in a year or whatever you need to be seen, and if you come back, great. If you don't, well, I guess you're doing okay. I still have patients to this day that they'll say, well, I guess if I don't hear any lab results from you, no news is good news. And I say, absolutely not. You have to hear from us one way or the other. If you don't hear from me, then you call me, because if that and the medical home certification relies on closing those gaps, making sure those things are done, and making sure that we actually have statistics, behind that. So saying, setting goals for saying, well, 100% of the time we want this to make sure this done, because if it's only 95% of the time we're calling people with their test results, somewhere eventually we're going to miss something, and we don't want that to happen.
Here's another great question for you. Will adult children be able to access medical information for their elderly parents and also be able to express concern?
Okay, read that one again. I'm still...
Okay, this is coming in. Will adult children be able to access medical information for their elderly parents and be able to express, in other words, communicate?
Yeah, great question. Yeah, that's a great question. The system is, the intent of setting the system up is to enhance the communication amongst patients, providers, and family members. In fact, one question was about what are some of the requirements of medical home. That's one of them, is making sure that we identify who is the responsible communicating party on the part of the patient. So if it's and we see it all the time in terms of, I deal with sons and daughters of patients all the time, and it's the same requirement. Right now I still have to have someone sign a piece of paper that says it's okay to talk to Susie about Dad's records, and same thing is true here.
You mentioned that this model encourages a more holistic approach to care. Can you explain what holistic care is and give examples? Yeah,
I would say, that's actually a good question, because holistic has a lot of different connotations. It's not like we're doing massage therapy and acupuncture in the office. I think it is more about looking at the level of complexity needed for a particular patient and making sure that all of those resources are available. So an example of that might be, if you're a 25-year-old, you have a family history of high blood pressure, but you're on no medicines, you're in good health, there's not much interaction with your doctor's office. You come in for your annual physical, we make sure we check things from, on that annual basis, we're done. Now, on the other hand, if you're that person's, great-grandmother and they're 85 living at home and they're falling at home and they haven't broken a hip yet, but they're on lots of medicines, they're confused, they're still driving and they probably shouldn't be driving, then when we talk about holistic, we talk about, okay, let's bring in the relevant family members, let's get a social worker involved, let's get aging services involved, and get all these people into a room, get a pharmacologist, for example, a PhD pharmacy person, our health coach, all the people that have an opportunity to impact this care, and have all those people talking together. Because the traditional model of this is not only would we have missed grabbing all of the right people to have the conversation, those people never would have been in the same room together. So now It's formalized care plans. How do we care for these patients? How do we keep them out of the hospital? And how do we keep them from getting hurt?
Question about cost. Question is common to hear that preventive medicine will ultimately lower healthcare costs. Do you have an example of how much money we're talking about
Wow,
here?
this is a huge area of debate. And there are conflicting reports. The best data I've seen shows that depending on the disease process, the more we are able to manage diabetes, for example, that's the big one. And part of it's because diabetes, there are so many illnesses that go with diabetes. There are good numbers out there in terms of the dollars you spend on prevention. If we manage diabetes very well, out of a large population, you're going to prevent multiple bypass surgeries, for example. And a lot of the dollars that we prevent care, it's astounding, the impact. And I don't have the numbers in front of me, so I'm not going to quote anything, but there are research papers all over the web that can tell you that. The difficult thing, and I think part of what's at the heart of this question is, take a 25-year-old healthy person again. They have no medical conditions, no family history. Their cholesterol's fine, their weight's fine, their blood pressure's fine. If you invest a lot of dollars in making sure those people stay thin and healthy and do what they should do for caring for themselves, what is the return on investment for that? And that's the challenge for a large self-insured employer. So what we've done is try to look at the data that's available and try to assist in that conversation of where's the best value for the resources that you have out there. Because part of the argument, quite frankly, is keeping people healthy, attracting a healthy workforce, using it as a recruiting tool if you're a corporate employer, and we deal with that at Mercy too. We want to provide an environment where our employees are happy, that they're healthy, that they feel cared for, and have the resources they need. When you look at really extremely the sickest of the sick people, where I might have a patient that's a diabetic and in and out of the hospital 3 or 4 times a year, that return on investment from a community standpoint is very easy to justify. I mean, I put resources in helping those people because they need it and it's the right thing to do, but the way I can turn around and justify that to people who are paying the bills are, look, if I can keep them out of the hospital one of those 4 times, that we paid for all this. So there are lots of incentives for that.
Well, as a follow-up to that, we have a question related to that. What is the biggest advantage of this new model? Is that what you see as the biggest advantage?
Yeah, I think a shared responsibility and accountability for our health care. We traditionally spend lots of dollars in the healthcare system on the tail end of a disease process or solving problems that could have been prevented, or even if they couldn't have been prevented, they could have been managed more aggressively to the extent that the ultimate cost was reduced. So strictly from a cost standpoint, it's an easy model to justify. What I prefer to do, I use the cost argument when I'm talking to people that are worried about costs because they need to be reassured that their needs are met. When I talk to a group of physicians or patients, I focus on the quality piece because there's no doubt in my mind. We've done several research trials with hundreds and hundreds of patients, and it's just crystal clear that when you put this type of support around a group of patients, they become more engaged in their health care. They understand what they're dealing with. They understand what the different types of cholesterol are and how it impacts them. We can show them the probability of getting heart disease from smoking, for example, and they're more likely to get the cancer prevention tests and their immunizations done that are recommended for everybody. So there's no doubt in my mind. We have lots of data to show that it improves the quality of care.
Great. Question about the logistics. Will there be any interruption of care for the patient during this transition to the new form of health care, or do you perceive it will be a smooth transition?
Well, I think that there's no doubt that it'll be a smooth transition. It is a very subtle thing that if you're not paying attention, you might even miss it, because a lot of what's going to be going on is behind the scenes. For example, see, I saw a diabetic in clinic this morning, and I spent the same amount of time I typically spend with him. We talk about the same things. In fact, we actually had a little time to talk about some social things too, because a lot of the testing, I used to be in there in the room kind of, trying to talk them into doing the test that we should be doing. But if they don't really understand that, there's not a reason for that other than, hey, my doctor says I need this. The interesting thing is that when you get into that type of model where the patient understands that and those things are already done, it doesn't really appear to you that that's going to be very different, except that you understand you have a better understanding of what's going on. But in terms of how you're in and out of the doctor's office, no, there's not really a change there.
Okay, very good. Another question, if I don't have any chronic diseases that need to be managed, okay, I lost my spot here, just a second here. Okay, if I don't have any chronic diseases that need to be managed, how does this model benefit me?
I think it comes down to, we know that we want more and more people healthy, so we want more and more people to be on that end of the health spectrum, which is, yep, nothing wrong with me. And probably the best analogy I can use for this is the fact that we do pap smears that, for age-appropriate cancer, cervical cancer screening in women. That's an exam that I'm, as a physician, looking for the one person out of 100 who has some sort of abnormality that could lead to a cancer. Now, that's a wellness measure. So the overwhelming majority of pap smears that we do are completely normal. And you could even argue, why am I even doing this as a patient? Because they're always normal. But again, if you're that one person, then it saved your life. So making sure, it's more about making sure that the things that should be done are being done. Another example is, screening for depression. That's one of the things we're quote unquote supposed to do on an annual basis. We're also supposed to check if you're a smoker at every visit to your doctor. So think back to your last doctor visit or last 2 or a dozen or 100 doctor visits, and how many times have you been asked about depression or smoking? And again, those things may not apply to you, but the one time it does apply to you, it's all the difference in the world.
It sounds like this new model will require practitioners who are used to functioning independently to work in a team environment with the patient present. What do you see as the key to overcoming the challenges for these practitioners to work together as a team?
Wow, that's a good question. So that really strikes at the heart of the matter, and whoever's asking that question has a very insightful view of how the healthcare system works. When you ask physicians why they went into medicine, most of us will say, well, it's autonomy, it's people not telling me how to do my job, I can focus in on relationships with patients, and then that's what I want to do. And certainly to me, that was a huge appeal for me for the medical field. But ultimately, what I came to realize was that there's only so much one person can do in terms of quantity and quality. And the only way I was going to get to the next level in terms of engaging patients, having a staff that's involved, having a full team resources, was going to be the only way. I cannot possibly remember to do 20 things in an office visit with an 85-year-old lady who's, in tears because her husband died 2 weeks ago. It's just, I'm not going to sit and ask her about, her smoking or colonoscopy. It's just, as you can see, it's not appropriate. So we need a team of resources around, hey, what about this, what about that? Maybe they contact the patient at a different time. We don't use that critical time necessarily face-to-face to do every piece of that. So, to answer your question, how do we make that transformation of culture, which is what that is. It's a cultural question. It's about how physicians view the environment. It's about how nurses view the environment. The way you build that bridge and change the culture is building the vision for how it needs to be different and why it needs to be different. And when you come out with examples like the video we showed with Dr. Myers' visit, that's a person who Dr. Myers is one of the strongest physicians in this community. That's an excellent physician with good resources in a well-supported clinic, that a patient that could have easily been missed and then found later at stage 4 colon cancer and given a terminal prognosis. So despite our best intentions, we have to use those kinds of stories to help people understand why it's such a compelling model.
That is a compelling, compelling story right there. One of your earlier slides, you mentioned health coaches. I've never heard of a health coach before, and can you tell me a little bit more about that concept?
The health coach is a position we created in our system about 3 years ago. We started at one office. It's a person who works closely with my nursing staff. As you can imagine, if there are any nurses listening, the nurses are just, they're just running around with their hair on fire all day. They have a million things to do. They're worried about accuracy of medications, all the patients they have to take care of. And in the clinic setting, those nurses are rooming patients, ordering tests, following up on tests, answering the phone. So for me to sit down and go, can you go through these 100 charts of patients I'm going to see in the next couple of days and make sure they all have had colon cancer screening, mammogram screening, their cholesterol tests, and their diabetes tests are all to date. Oh, and can you see when their last tetanus shot and pneumonia shot was? Well, that's laughable, right? There's no possible way to do all that. So what a health coach does is they review all the old records, make sure that I'm all up to date on everything, and if they're not, they leave me a note that says this person is due for this and this. They develop the health care plan that I actually hand to the patient that says, here's your cholesterol, here's when the next one's due, here's your cancer screenings that are due and when. You had, for example, a spot on your lung x-ray, and we want to follow that up with another CAT scan or something in 6 months. Here's your blood pressure today, and here's what your blood pressure goal is. So it's developing that health care plan that I then hand to the patient. And then if there's some follow-up things, people who are having emergency room visits or have been in the hospital, then the health coach reaches out to the patient and says, okay, when is your follow-up due, or make sure you come in tomorrow to see Dr. So-and-so as they asked you to do, and how are you doing, by the way? And let's go through all your medicines and make sure you're actually taking the medicines that we discharge you from in the hospital. I can tell you it's not less than 3 or 4 times a week where an elderly couple comes into my office with a Tupperware tub full of medicines, half of which they don't use and half of which they don't know what they are. So having some sort of coordination point is a lot of what those health coaches do.
In fact, we just had another question come in related to that. Will my patient portal and an electronic health record show all my prescriptions so I don't have to keep a separate list with me at all times?
Yeah, that's a great thing about this web portal. So, you're at home or wherever you are, even some smartphones will be able to get access to this. You log in through a secure web portal. You have a unique identifier for you. You can get to your medication list and even print it out or download it. So it's really slick.
And related to that, will my personal physician be able to see all my medications, even the ones prescribed by a specialist, and tell me if the medications will interact?
So the challenge with all these, electronic records is getting them to talk to each other when you go to different specialists. So within Mercy, we have that ability to see all that. Right now, we don't have the ability to see if someone did it today. Now, what happens is my nurse communicates with a surgeon's office and then updates it in my list. So I get the updated version that checks for interactions. The software fix to that, where all those things will automatically happen, is still a few months away, but that's where we're headed.
Great. That's a wonderful plan. To confirm, the Mercy referral line is 319-369-4444 and is answered from 8 to 4:30 Monday through Friday. Also, you can find MercyCare Doctor at mercycare.org/doctors. I believe we have covered all questions submitted to us, but again, if you have additional questions, please call 319-432-1406. A tape of this program will be available at www.mercycare.org/live, and you can just check this website for information about future webinars. In fact, you can see on your screen right now the next webinar will be Tuesday, March 8th at noon. You'll join Colleen Moore of Mercy's Cancer Genetics Program to learn the basics of colon cancer and hereditary colon cancer symptoms. And then Colleen will take your questions live after her presentation, just as Dr. Quinn has done with us today. We check to see if we have any additional questions that have come in. Nope. Okay, well, Dr. Quinn, thank you. Oh, Oh, we have one. Excellent job, everyone. Yay, we'll take that question. Dr. Quinn, thank you so much for your help. Lots of good questions.
Thank you.
And thank you all for joining us today.